It is my feeling that periodontal disease can be cured and not simply controlled. And the basis of that begins with the difference between a periodontal defect and a periodontal pocket. What is a periodontal pocket? It exhibits increased probing depth, infection is present, bleeds on probing, exhibits suppuration and inflammation, whereas a periodontal defect exhibits increased probing depth, is not infected, does not bleed on probing, does not exhibit suppuration or significant inflammation, is stable over a long period of time, and exhibits no additional loss of attachment, and radiographically shows crestal density. So you see there is a difference between a periodontal defect and a periodontal pocket. How does this relate to periodontal disease? And in this position paper published in 2011 by the American Academy of Periodontology states, health is characterized by the absence of inflammation, which may appear clinically as redness, suppuration, and bleeding on probing. That is health. But I do not agree with one word, by the absence of inflammation. The reason being, I don't think it is possible to have an absolute absence of inflammation. But what we want to do is to reduce the level of inflammation to an absolute minimum. Increased probing depth. A probing depth of over 5 millimeters is considered to be a periodontal pocket. The treatment focus is on pocket elimination. Infection is present. Further, studies show that probing depths of over 5 millimeters can limit calculus removal, and this is a classic article by O'Leary and his co-workers published back in 1990. Bleeding on probing is a classic sign of periodontal disease. On the score sheet that is used by students on the Miller-McIntyre Prognostic Index, we have this on the back. Quantitative bleeding on probing. And this is something that I think needs to be emphasized to all dental students. What is slight bleeding on probing? This is a trace. For example, if you probe number 18 and there's no bleeding on probing, but by the time you get to 20 or 21, a little blood has oozed out. That's a trace, probably not significant. Moderate bleeding on probing is where you place the probe, and as you pull the probe out, blood follows the probe. Severe bleeding on probing is where as soon as you enter the pocket, we get profuse bleeding on probing. So I think this is something that is new and different, should be taught to every dental student, and we need to have a better understanding of the level of bleeding on probing. Suppuration. Suppuration is the process of pus forming. The exudate results from an infection, and the result is tissue destruction. The difference between inflammation and infection, and I think this is very important. Infection is the cause, whereas inflammation is the body's response. But we must understand that inflammation is a double-edged sword, because if we're going to have healing, we need to have inflammation. By the same token, it also causes tissue destruction. We need to understand how inflammation works. This is a lipid mediator or mediators which control the magnitude and duration of inflammation. They are biosensitized from omega-3 fatty acids. How does this relate to periodontal disease? In the slide that I showed you earlier, where I disagree with the term absence of inflammation, for it appears to me that there's no way that you can completely remove the inflammation. What are the objectives of periodontal treatment? First of all, we would like to eliminate the pocket. Second, we want to minimize the body's inflammatory response to irritants. This could be bacteria, this could be calculus, this could be an overhanging restoration. Although it is impossible to eliminate all inflammation, reducing it to a level where there is no bleeding on probing or further attachment loss is our basic objective. And converting a periodontal pocket to a periodontal defect, and we have already defined what a periodontal defect is. The keys to successful treatment: brush and clean interdentally all tooth surfaces effectively on a daily basis. Clean your tongue daily. And you remember, we have repeatedly talked about the importance of cleaning the tongue and removing the sulfur-forming bacteria in that area. Third, complete the recommended periodontal treatment. And certainly if the patient does not complete treatment, there is no way that we can have success. Adhere to the recommended maintenance schedule. If we're going to have success, obviously we have to have adequate maintenance. Control the blood sugar if the patient is diabetic, and as we've talked about in the smoking video on cessation, to stop smoking. For if two patients have the same level of periodontal disease, statistically, the patient who smokes has a 247% greater chance of losing their teeth. And I'll direct your attention to the video on smoking cessation. This is a score sheet that we use in doing a periodontal exam, and you will notice in the lower right-hand corner the key factors that I just mentioned are published there. The conclusions: to cure periodontal disease, we must remove all irritants and minimize inflammation. This not only requires impeccable brushing and interdental cleaning, coupled with the removal of the sulfur-forming bacteria on the posterior 1/3 of the tongue, and using the most effective, least expensive mouthwash. Remember, that's a sodium hypochlorite. If the mouth is sterilized, although there may be excessive probing depths, I feel that we now have a periodontal defect and the disease on that patient has been cured.